Dr. Adele, I think we should start.
Yes, please. I think so.
Okay. Good morning, everyone, our senior colleagues and colleagues. So we welcome back to this new year's set of academic presentation. So these are first for this year of 2024. And then, so we'll be starting with by discussing one condition that we face most commonly as ophthalmologists. And it's something that it can also, the management can be quite challenging. And we have Dr. Abdulrahman Dogo, a senior registrar from Asokoro District Hospital, who would enlighten us and tell us more about the pathophysiology of central retinal vein occlusion, and also the indications and, indicating the modalities of treatment. So Dr. Abubakar Dogo, so as not to waste much time, we will not mind if you can start the presentation now. Thank you.
Okay. Good morning, everybody. Good morning, senior colleagues. Good morning, colleagues. As the host have said, my name is Dr. Abdulrahman Dogo. I work with Asokoro District Hospital. I will be taking us through this a discussion on the pathophysiology of central retinal vein occlusion, and also be indicating the modalities of treatment. And I would like to do that. Hello? Hello, can you hear me?
Yes, we can hear you.
Okay, so I'll try to do that using the following outline. I'll first I'll take us briefly on the anatomy of the retinal vein, then the epidemiology, the risk factor, pathogenesis, and pathophysiology. Then for us to be able to talk about different treatment modality, it's important for us to know different types of or classification of retinal vein occlusion. What are the common presentation with each and every one of them? Then how do we evaluate then different treatment modalities? I also briefly talked about the complication that is likely to occur with treatment, and then I'll talk about the prognosis and follow-up. I talked about the differential diagnosis, then conclude and state my reference. As a form of introduction, retinal vein occlusion simply means obstruction of the retinal venous system, most commonly caused by thrombus formation. It's said to be commonest cause of reduced vision due to retinal vascular disease. Is second just only to diabetics retinopathy. And central retinal vein occlusion is usually unilateral disease, but however, it may develop in the fellow eye in 1% of patients within 1 year or 1 year of the first eye, and then 7% of patients within 5 years. The occlusion of central retinal vein may occur at the lamina cribosa, or area that is posterior to the lamina cribosa. And occlusion posterior to the lamina cribosa is usually due to atherosclerosis compression of the central retinal artery. As we all know that they share common adventitious. A brief about the anatomy of the retinal vasculature. As we all know that the orbit is being drained by main four quadrant of the fortress vein, and then as you can see in this picture, we have the superior lateral fortress vein, the superolateral fortress vein, and then superomedial. The other one, the inferior medial and inferior lateral, cannot be shown in this picture. Then all the four quadrants, they eventually drain into the superior orbital vein, which eventually ends in the cavernous sinus. So in this picture, you can see that we have the central retinal vein as it's coming into the globe. Is divided into two major hemiretinal veins, which is superior and the inferior. And then each of the hemiretinal vein now divided into the superior superiolateral, superior-nasal, and then superior-temporal. And then the same thing happened to the inferior hemiretinal vein, divide into inferior nasal and inferior temporal. Then the same thing, then after it comes out from the optic nerve, it now go to distribute different part of the retina. So usually in about 20% of individuals, they may have a dual trunk, meaning that instead of it coming as a single trunk coming out, then it divided into superior and inferior hemiretinal vein. It can be that it is two trunk that is coming through the retina. So talking about the pathogenesis, it's important for us to know how much the epidemiology of this retinal vein occlusion. According to the Beverdam studies, which report a 15-year cumulative incidence of a branch retinal vein to be 1.8%, and for branch retinal vein, and 0.5% in central retinal vein. And it has a prevalence of 0.1% in patients, which are usually greater than 43 years. Branch retinal vein account for about 69.5% of total retinal vein occlusion. It occurs in 5 to 6% in 5th to 6th decade of life, and 90% of central retinal vein occur in patients greater than 50 years of age. And then there's usually equal predisposition in terms of male and female gender. It's said to be common, the central retinal vein common more in Hispanic origin than those white, than Asian, and then black in this following distribution. The non-ischemic central retinal vein occlusion is more common than ischemic central retinal vein occlusion. So talking about the pathophysiology, so we want to highlight what are the risk factors for a person to even develop the retinal vein occlusion. It is said that the most important risk factor in developing the retinal vein occlusion is the age, as 50% of cases occurs in patients older than 65 years of age. Other risk factors include any condition that can cause compression of the retinal vein itself, like external compression, as shown in the picture earlier. It is known that the central retinal artery and central retinal vein, they share common adventitia. So if there's compression of the central retinal artery, then it can lead to, if there's atherosclerosis of central retinal artery, it can lead to compression of the retinal vein. So atherosclerosis is one of the commonest causes of compression of central retinal artery. And the causes of atherosclerosis include the systemic hypertension, diabetics, and hyperlipidemia. It's said that systemic hypertension is present in 2/3 or more of retinal vein occlusion patients that are of 50 years and above, and in 25% of younger patients. So, and then the diabetics, it is present in 15% of patients that are greater than 50 years. Then the hyperlipidemia, they present with 1/3 or more of patients, irrespective of the age of the patient. Other condition that can compress the central retinal artery is the glaucoma. It's said that patient that has glaucoma has 5 times more likelihood of developing central retinal vein occlusion than normal patient that does not have glaucoma. Other things that can cause compression include cavernous sinus thrombosis, thyroid eye disease, and then papilloedema. Then other risk factors, disease of the blood vessels itself, the retinal vein itself, any condition that can cause disease retinal veins, which include systemic vasculitis like tuberculosis, syphilis, systemic lupus erythematosus, and HIV/AIDS. And then local inflammation, also like sarcoidosis, serpiginous choroiditis, can also cause disease of the blood vessels of the retinal vein. Then other risk factors, the hematological factors, like now we've talked about the external compression, we've talked about the blood vessels wall. Then now we are talking about the blood constituent itself. Anything that can cause hypercoagulability state of the blood vessel, where we have clotting disorders like protein C, protein S deficiency, lupus, anticoagulant deficiency, antiprotein C resistance, and the antiphospholipid. All these cause hypercoagulability state of the blood vessels in itself. Also, among them is paraproteinemia, like multiple myeloma and cryoglobulinemia. And then other risk factors like blood dyscrasias, like lymphomas, leukemia, polycythemia rubra, and sickle cell disease are also implicated. Also implicated are drugs like oral contraceptive medication and diuretics. Smoking is also identified risk factor, because it's known that smoking is a predisposition to atherosclerosis, even hypertension. Then hypermetropia is also identified risk factor, and congenital anomaly of central retinal vein is also identified risk factor. So, talking about the pathophysiology, as I said earlier on, that central retinal vein and central retinal artery share same common adventitia as they cross through the lamina cribosa. So any condition from the highlight mentioned risk factor, all those risk factors that I mentioned earlier on, any condition that cause vaso-occlusions, then that now cause occlusion of these blood vessels, like central retinal artery, then this now leads to elevation of the venous and capillary pressures. There is going to be a backlog of blood, as in there is no drainage in the venous system. So there is going to be elevation of venous pressure and then capillary pressure. Then further, the stasis of the blood inside the blood vessels also leads to retinal hypoxia, because the distance area that is supposed to be supplied by this blood is being deprived of oxygen that is required. So it leads to hypoxia with resultant damage to the capillary endothelium. So when there's now this damage to capillary endothelium, you know, that one is another compromise for blood vessels to, for blood to leak out from the lumen of the blood vessels, then leading to extravasation of the constituents of the blood into the tissues. And then also the hypoxia also stimulates production of vascular endothelial growth factors, which also bring about production of new blood vessels, which are not as potent as the main blood vessels. So all these enhance capillary permeability and more vascular leakage, then leading to macular edema. So it's a kind of a vicious circle. So when there's venous occlusion, it causes stagnation. Then the stagnation causes hypoxia in the distal tissue that's supposed to be drained. Then when there's hypoxia, there's compromised blood vessels, which also lead to further extravasation of blood. And then from there, also there's a production of vascular endothelial growth factor. Then all this leads to edema and then hemorrhage. And then all this also increase the tissue pressure further. Then the increased tissue pressure also leads to further stagnation. So the physical cycle tends to continue until when something is done in order to break this cycle. So to talk about the treatment, it's important for us to talk about the different classes that we have. We have central retinal vein occlusion, which can be non-ischemic and can be ischemic. It can be, Then we have the branch retinal vein occlusion, which can be any of the major branch, like superior temporal, inferior temporal, or inferior, or the macular branch of the retinal vein. Then it can be hemicentral retinal vein occlusions. One of the main retinal vein may be occluded, and that one too can be ischemic and can be non-ischemic. So the non-ischemic type of central retinal vein is also refers to as phonostasis retinopathy. It is more common than the ischemic type form, and it occurs in 75%. It occurs in 75% of patients with 75% of retinal vein occlusion is non-ischemic. So around 1/3 of patients with non-ischemic central retinal vein will later progress to ischemic form, often within months of onset of the occlusion. Then what are the clinical presentation of non-ischemic? They usually present as a kind of sudden painless monocular decrease in visions, and other systemic disease, symptoms of the systemic disease that cause the occlusion. So they can present with that. So usually for non-ischemic central retinal vein occlusion, their visual acuity is variably impaired in terms of it's not as severe as we have in that of ischemic type. So usually their visual acuity is usually 660 or below. But if you have a visual acuity less than 660, so the visual acuity in non-ischemic is usually 660 or above, or more than that. So if you have visual acuity less than 660, is usually indicating a kind of ischemic type of retinal vein occlusion. Usually, and then the anterior segment, you might have a kind of mild or even absent pupillary defect or iris neovascularization. Usually, you may see iris neovascularization or it may not be there, unlike as it's more common in the ischemic type. Then on gonoscopy, neovascularization of the anterior chamber may be seen. The IOP elevation in the eyes are initially as I mentioned during the risk factors, that glaucoma is a risk factor for developing a retinal vein occlusion. So patient may have a raised IOP ab initio. Then after that, the retinal vein occlusion now develop. Then the neovascularization in the angle can now develop, or even the retinal vein occlusion itself can lead to neovascularization, and then which can now lead, as in what we usually refers to as orange days glaucoma, when there's new blood vessel clotting on the trabecular meshwork. So on fundoscopy, what you usually see, you see all signs in all quadrants in central retinal vein occlusion. You usually see tortuosity and dilation of branches of retinal vein, central retinal vein. This is what we call battlefield appearance. The battlefield appearance, like you splash blood on the retina. So you can see that tortuous blood vessels, you can see dot and blood hemorrhages, you can see, which are usually mild to moderate depending on the extent of the condition. You can also see continuous spots. Then on the optic nerve, you can see mild optic disc and macular edema. You can see mild optic disc edema. Then what is more common, especially in younger age group, is patchy ischemic retinal whitening, which is usually seen as a kind of periphenular whitening It's usually common in younger age group. This is what it is shown in the arrow here. Then on fundoscopy, the late findings usually most of the acute symptoms or signs usually resolved within 6 to 12 months. Then the late findings may include persistent scattered retinal hemorrhage, venous tortuosity, sheathing and sclerosis of the blood vessels, retinal gliosis, macular pigmentary and atrophic changes. Then peripheral optic disc collateral vessels may also be seen. So for ischemic central retinal vein occlusion, it's characterized by substantial decrease in retinal perfusion with capillary closure and retinal hypoxia. So this one is significant hypoxia in this type of condition. So it usually presents with sudden severe monocular painless visual loss. They may present with pain, redness, and photophobia due to neovascular glaucoma, so which is not very common as the case of non-ischemic type. Usually, they don't usually present with pain or redness and photophobia. So, but in ischemic, if there's a neovascular glaucoma, so it may be associated with pain, redness, and photophobia. Then on examination, the visual acuity is usually cantifinger or worse. So you can see now in ischemic type, they have worse form of visual acuity. And then the anterior segment congestion may be noticed. You can see the injection of the conjunctiva and the neovascularization. Then you can also see corneal congestion, edema, because of the neovascular glaucoma. Usually common with them, you see RAPD, relative afferent pupillary defect. Then iris neovascularization is usually common in 50% of eyes within 2 to 24 months. 2 to 4 months, sorry. So unlike that we have in the ischemic type. And then on gonoscopy, you see in the angles, you see neovascularization and along the pupillary margin or in the angle. Then here you have a severe tortuous and engorgement of all branches of a retinal vein. You can see here, this is more of that battlefield appearance with more extent now. Then extensive blood and flame-shaped hemorrhages you can see at the posterior pole of the fundus and also in the periphery. See cotton wool spot, see optic disc swelling, and then hyphema. Then optic disc, you can also see collateral circulation in some up to opticociliary shunts as shown in this picture. Then retinal neovascularization is seen in about 5% of the eyes. Then their late findings include retina, atrophic retina, retinal pigmented epithelial changes at the macula. You can see RVE hyperplasia. You can see epiretinal membrane. You can see chronic cystoid macular edema. You can see subretinal fibrosis. However, the acute symptoms usually resolve between 9 to 12 months. Then later you now see these late features that I mentioned. So for form of investigations for patients, for you to be able to treat them, to manage properly, you need to do some form of systemic investigation as shown by the risk factors. So you want to find out what are those risk factors, what are the causes of this retinal vein occlusion. So extensive systemic workup is very important in patients, especially if the patient is less than 50 years of age. As we said, age is one of the major risk factors. So if that it common among the elderly patient from 5th to 6th decade of life. But if you now see a patient with retinal vein occlusion and the age is less than 50 years, you want to really find out what is really causing it. Then you want to do fasting blood sugar, you want to do lipid profile, electoral urea and creatinine, clotting profile, full blood count and blood film, plasma protein electrophoresis, thyroid function, and thrombophilia screening. So all this is pointing towards the highlighted risk factor, all those risk factors that I mentioned earlier. So that's why you are doing all this systemic workup. Then also it's important to do fundus autofluorescence. So on fundus autofluorescence, in acute central retinal vein occlusion is characterized by a fan-like periphenular hypoautofluorescence. It may be seen. You can see these are the venules. You can see periphenular hypofluorescence. You can see. So in a form of fan-like appearance. So this is due to masking of the background retina by the edema. Sorry, I need to charge my laptop. So just think. Sorry, please give me some second. I hope I'm still audible, Sha. So, hello.
Hello,
You
yes,
are
we
on.
can hear you.
Sorry, please give me some minutes. I need to charge my laptop. So, fundus autofluorescence usually is due to masking effects of the grand retina by the edema. Then fluorescein angiography is also important. You see a kind of delay. You see a kind of a delay in the arteriovenous transit time. And then you also see masking by hemorrhage. You see good retinal capillary and good retinal capillary perfusion in the non-ischemic type. So when you do fluorescein angiography, there's usually good capillary perfusion. And then there's also late leakage. Then for the ischemic type, in ischemic type, you see marked delay in arteriovenous transit time. You see masking by the retinal hemorrhage. And then there's extensive area of capillary non-perfusion. So usually greater than 10 discs diameter as shown in this picture. Extensive area of capillary non-perfusion and first wall staining and leakages. Then also important is the optical coherence tomography. It's used in assessing the system macular edema. So the patient, so the OCT will be able to highlight cystoid macular edema. And it's usually mild in the non-ischemic. The macular edema is usually mild in the non-ischemic and usually severe in the ischemic type. Then also important in is electroretinogram. You see a reduced B wave amplitude, and then of course, if there's reduced B wave, so B to A wave ratio will also be reduced. Also, B to A wave ratio is said to be less than 1. It's suggestive of ischemic type of central retinal vein occlusion. So this one, for purpose of summary, in highlighting the difference between the ischemic and the non-ischemic type, you said that the non-ischemic is the most common type among the two. So it accounts for 75%, while the ischemic accounts for 25%. So the visual acuity in the ischemic type is usually worse than 660, as mentioned earlier on, while that of the non-ischemic is usually better than 660. So there's marked involvement of RAPD in the ischemic type, where there may be slight or even absent of or normal pupillary reaction. So there's usually common visual field defect in the ischemic type, while the visual field defect is usually rare in the non-ischemic type. Then fundus findings is extensive. You see extensive hemorrhages and cotton spots in the ischemic type, and less extensive hemorrhage and few cotton spots in the non-ischemic type. On fundal fluorescein angiography, you see widespread capillary non-perfusion in the ischemic type, where you see good perfusion in the non-ischemic type. Then electroretinogram, there's reduced B wave in ischemic type. There's reduced B wave in the ischemic type. Then the prognosis for the ischemic type, 50% develop rubiosis and neovascular glaucoma in the ischemic type, the 100-day glaucoma that I mentioned earlier on, while 3% develop rubiosis and neovascular glaucoma in 50% of in the non-ischemic type. So what are the causes of visual impairment in CRVO? Usually it is due to chronic macular edema, secondary optic disc atrophy, macular ischemia, neovascular glaucoma, vitreous hemorrhage. So these are the common causes of visual impairment in patients with retinal vein occlusion. Then the treatment principle or different treatment modalities. So the aim of treatment could be, 1, to treat the macular edema, 2, to manage the anterior and posterior segment neovascularization, and then management of established neovascular glaucoma, and then the treatment of vitreous hemorrhage that may occur as part of the complication. So you want to identify all these complications and manage them as such. So you want to, if there's a macular edema, you want to treat macular edema. If there's a neovascularization in the anterior and posterior segment, you want to do that. And then if there's established neovascular glaucoma, you want to address, and then vitreous hemorrhage. So the treatment modality, generally, treatment of macular edema is indicated when the visual acuity is worse than 6.9, or if there's significant central macular thickness greater than 250 microns on OCT. So these are the reasons why you want to treat the macular edema. And of important in the treatment of the macular edema is the intravitreal anti-VEGF and intravitreal steroid, what are commonly used. For intravitreal anti-VEGF, ranibizumab, according to cruise and horizon studies, it shows that intravitreal ranibizumab is a parallel studies which study both the efficacy and then the safety of this ranibizumab. So it shows that there's a significant improvement in visual acuity and resolution of macular edema due to central retinal vein occlusion. So, but the ranibizumab is a pan-VEGF-A blocker, which selectively binds to human vascular endothelial growth factor A and prevents it from binding to its receptor. It's usually given in 0.5 milligram in 0.05 ml, usually given as a monthly regimen. So for like 6 months initially. Then if the patient now warrants more treatment, it's based on the OCT findings. Then it shows that from this study, from these cruise and horizon studies, it shows that the covers the ranibizumab give 2 to 3 line gain in visual acuity. Then the aflibercept, so it's a pan-VEGF-A and VEGF-B, and also placenta growth factor blocker. So it works on VEGF-A, VEGF-B, and placenta growth factor. As evaluated in Copernicus and Galileo study, the 2 milligram of intravitreal injection was found to cover a gain of 15 or more EDTA letters of best correct visual acuity from baseline at 24 weeks. So after 24 weeks of giving 2 milligrams of intravitreal and aflibercept, they're usually up to 15 or more letters gain in visual acuity after 24 weeks. So for bevacizumab, it's a recombinant human mononuclear immunoglobulin antibody that binds to and also inhibit vascular endothelial growth factor. Most common treatment regimen is 2 to 3 injection of 1.25 milligram in 0.5 mils over 5 to 6 months. And it's also caused a significant decrease in macular edema and also improve the visual acuity within the 3 months of injection. Then intravitreal steroid, corticosteroid reduce the retinal capillary permeability and inhibits expression of vascular endothelial growth factor gene. So it has two modality. It has two mechanism of action. The steroid, it reduces the capillary permeability. As I mentioned during the pathogenesis, that there's usually release of VEGF and which lead to extravasation of the blood. So the steroid tends to work on preventing the expression of vascular endothelial growth factor gene, and also prevent its metabolic pathway. Usually, if steroid is given, it has short half-life, but with Oxudex, which is a biodegradable implant, with dexamethasone, so it has sustained release, so it has a longer duration of action, and it's also biodegradable. So according to Geneva trials, it analyzed substantial visual and anatomical improvement over first 2 months of following treatment. So if within the first 2 months of treatment with Oxudex, according to Geneva trials, there's usually both anatomical and visual improvement, and the treatment can be repeated after 4 to 6 months. Then intravitreal triamcinolone, according to SCORE studies, it analyzed the use of intravitreal triamcinolone, which shows improvement of 3 or more lines of vision at 1 year in over 25% of patients treated with an average of 2 injections of 1 milligram triamcinolone. So these are the modalities, different. So there's intravitreal anti-VEGF for macular edema. There's also the use of steroid for macular edema. So, but some of the complications that can arise with the use of this intravitreal injection include injection site complication, elevated intraocular pressure, cataract formation, infectious endophthalmitis, steroid uveitis, and pseudohypopia. So management of the anterior segment neovascularization. So we have talked about the management of the macular edema. Now we want to address neovascularization of the anterior and posterior segment. And what is done in order to treat that is pan-retinal photocoagulation. This should be performed without delay in eyes with iris and angle neovascularization. So once you are able to establish that patient has neovascularization, you should do pan-retinal photocoagulation without delay. It's usually given 1,500 to 2,000 bonds of 0.5 to 0.1 second duration are usually made. And you must put a 1 bond space apart between the bonds. Treatments may be repeated as required by some patients and may be done in conjunction with anti-VEGF injection. So you can give pan-retinal photocoagulation and also give intravitreal injection. And this has been shown, the combination of this has been shown to have more rapid resolution of neovascularization than pan-retinal photocoagulation alone. So if you combine it with intravitreal anti-VEGF. Hello? 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 So if you
Continue,
combine
please.
pan-retinal photocoagulation with intravitreal injection, there is usually more and rapid resolution than only pan-retinal photocoagulation. This is a picture of areas of burns with pan-retinal photocoagulation. So for management of established neovascular glaucoma, if patient has neovascular glaucoma, so what is being done to address that? The aim, you should prioritize your treatment in terms of if the patient the eye is not seen. Wow. Sorry.
Hello, we can see your slides, but we can't hear you.
Hello?
Yes, please.
Yes, please. Go ahead.
Okay. So I can go ahead now. You can hear me and you can see my screen, right?
Yes.
Yes.
Okay. So I was talking about the management of neovascular glaucoma. So that the aim of treatment for a patient that has blind eye is to keep the patient free of pain, and you can achieve that by giving topical steroid and then topical atropine twice or once daily in order to prevent peripheral anterior synechial or posterior synechial. So in the eyes with visual potentials, if you see that there's probability that the patient can still see with, let's say, visual acuity of light perception or better than that. So you want to control intraocular pressure. And the best medication to control intraocular pressure in this case is apraclonidine and oral acetazolamide. Then pan-retinal photocoagulation in conjunction with intravitreal anti-VEGF will also help to regress the neovascularization. Then for treatment of vitreous hemorrhage, if patient has vitreous hemorrhage, significant vitreous hemorrhage, you want to give pars plana vitrectomy in this type of patient. And also when you do pars plana vitrectomy, you can also combine it with pan-retinal photocoagulation at the same time. The advantage of doing this is that when you do pars plana vitrectomy, it remove the opaque hemorrhage, so it clears your visual axis, and then it also increase the oxygen tension, so it increase the oxygen supply to the retina and also decrease the ischemia that may it decrease the ischemia after the central retinal vein occlusion and also prevent neovascular glaucoma. So my prognosis for non-ischemic central retinal vein occlusion, there can be complete resolution in 10% of patients, even so without intervention, if the occlusion if the problem is not that much, there can be complete resolution. But in about 50% of patients, they have visual acuity of 660 or worse. Then they may also have macular edema in 30% of patients within 6 to 12 months. Then 1/3 of patients progress to ischemic central retinal vein occlusion in 6 to 12 months. And then neovascularization develop in 33% of patients in 12 to 15 months. However, for the prognosis for the ischemia, greater than 90% of patients with have visual acuity of worse than 660 or worse. They also have macular edema resolve in 75% of patients within 15 months. Then neovascularization can develop in greater than 60% of patients in 1 to 2 years. Then about 10% develop retinal vein occlusion in the same or the fellow eye within 2 years of onset. Then vitreous hemorrhage is seen in 10% of patients by 9 months. Then for follow-up, patients with ischemic central retinal vein occlusion should be seen monthly for the next 6 months. Then you can now be seeing them every 3 months when you have done your intervention and you see that there's resolution for the next. You can now be seeing them every 3 months for the next 1 to 2 years. Patients with non-ischemic central retinal vein occlusion should be seen 3 monthly for 6 months. Then anterior segment examination and gonioscopy should be done to check neovascularization. Then these are the differential diagnosis to central retinal vein occlusion. It can be ocular ischemic syndrome, diabetic retinopathy, papillary edema, radiation retinopathy due to anemia. And this is my conclusion. Central retinal vein occlusion can easily lead to complete loss of vision in affected eye, especially with complication of neovascularization and neovascular glaucoma. So early identification of the risk factor and timely presentation of patient and early and appropriate management of complication is a key in order to prevent permanent visual loss in affected patients. And these are my reference. I'm so sorry for the break in the presentations due to network. Thank you, everybody. Hello.
Thank you so much for the presentation. Dr. Oyekule is off. I will stand in for him. That was a beautiful presentation, very detailed, so many illustrations. We can go through the chat. There are some questions for you.
I hope I can see
Do that, or I should read them out for you.
If you can read them, I will appreciate it. I hope I can.
All right.
Because
So
over time, so I may not see the questions.
all right. Somebody asking what is 100-day glaucoma?
Okay. 100-day glaucoma is a glaucoma that arises after central retinal vein occlusion. Usually said to occur in 3 months, which is like 90 days or within 100 days. Usually due to the fact that when there's ischemia of the retina, and then now lead to neovascularization, and then there's also neovascularization of the iris, then of the iris and the angle. Then this neovascularization now plugging the trabecular meshwork, preventing the drainage of aqueous. Then it now lead to raised intraocular pressure, and this is what is usually referred to as 100-day glaucoma.
All right. Then the second one is about how can glaucoma cause CRVO?
As I identified earlier on, that there can be a kind of, if there's glaucoma, there can be raised intraocular pressure, and this can compress on the retinal vein posteriorly. So if there's compression of the retinal vein, then all the sequelae of retinal vein occlusion develop in terms and all the clinical signs and symptoms as highlighted earlier on. So glaucoma is one of the risk factors for retinal vein occlusion. In fact, it's said that patients with glaucoma, they have 5 times likelihood of developing retinal vein occlusion than normal patients that does not have glaucoma.
All right. How can you differentiate ocular ischemic syndrome from ischemic central retinal vein occlusion?
ocular ischemic syndrome, from my own understanding, I think it is due to obstruction of, we are talking about central retinal artery now. We are talking about the arterial supply to the eye in terms of arterial, but in the retinal vein occlusion, we are talking about the vein. It is the vein that is occluded in this instance.
Yeah, even clinical presentation, they can differentiate the two. So anterior segment findings associated with pain, which
Yes,
is
yes.
more in the ocular ischemic syndrome.
Patients with retinal vein occlusion, if they have secondary glaucoma, they may present with pain and photophobia.
Yeah.
But it's more with ischemic syndrome. Ocular ischemic pain is one of the major presentation. But in retinal vein, it's not usually common for them to have pain in association with it.
All right. And always remember, central retinal vein, you always want to prevent glaucoma. And that's why you need to be proactive. All right. So those are the online questions, except we have people that want to contribute. You can on your mic and.
Okay. Good morning and thank you. My name is Dr. Agwadu. Thank you to the presenter for the wonderful work on justice to the topic. Mine is just to add on the investigation, especially for the ischemia, that we have the option of OCT angio too as well, in addition to either the fundal fluorescein angiography. So my observation again is that the OCT, sometimes people have OCT machine and they do not check the capabilities of the OCT machine. So most of our spectral domain OCT machine, if you look at it very carefully, there's that module for the OCT angio too. And sometimes even if it's there and it's not activated, it's just to contact the manufacturers or the engineers of the machine so that they can come and activate, sometimes at a cost, so that in the absence of that FFA, that OCT angio can serve the purpose too. Thank you. That's just my contribution.
All right. Thank you so much, Dr. Agwadu. I can see there are lots of people online. We appreciate all for coming, including our teachers, Professor Folashade, Prof. Regina Morgan, and colleagues, Dr. Sadiq Abdullahi, too, our very senior colleagues. We appreciate everyone. This is supposed to be an hour program. We have already passed it, the time scheduled by 9 minutes, but I believe it's worth it and we have achieved something for the weekend. So we'll be happy to see you in the next 2 weeks again. Thank you all for coming.
Thank you, sir. Thank you.
You're welcome.
Thank you, sir.
Mhm.
Thank you.